Hospitals are a mashup, right? It's a part auto repair shop. Hospital is a part luxury hotel. Hospital is a part food court, cafeteria with questionable food choices. It's a part science lab. It's a part soap opera. It's a part factory assembly line. Yeah, some hospitals even look like a part cruise ship without the relaxation, of course. And all of this mashup comes together in a cacophony of organized chaos, hybrid, polyplex. Every day feels like a reality show without a script, right? So hospitals, think about this, are classified as a service industry. But if you notice, their financial behavior seems to resemble that of a manufacturing industry. Why is that? You see, most businesses have two types of risks: business risk and financial risk. And hospitals, like any other business, also have these two risks. Business risk of an enterprise is generally measured by what is known as the operating leverage, or OL. So a higher OL, or a higher operating leverage, means higher business risk. This is because the component of fixed cost is higher relative to overall costs. And this is typical of manufacturing companies. And as we know, and we will see, is also typical of hospitals. A consulting firm, in contrast, has a high variable cost and therefore low operating leverage. Financial risk is the level of debt in a system and the ability of the enterprise to service such a debt. So, hospitals, even though they are classified as a service industry, but because of high OL, which is the high operating leverage on account of the high fixed cost, exhibit the behavior of a manufacturing services, of a manufacturing enterprise financially. And because most hospitals are also highly financially leveraged because of high levels of debt in the system, they're also highly risky financially. So the total risk, which is basically business risk multiplied by financial risk in a hospital, can be significantly high. Not only are hospitals complex, they are also hybrid beasts, a polyplex of sorts. In this slide, I attempt to highlight two key factors that give hospitals their dual Janus-faced nature. And we will examine these factors in some detail momentarily. Hospitals, firstly, occupy a financially hybrid position, balancing production and human services imperatives. So, although classified as a services industry, we will see how the financial behavior exhibits or demonstrates a production enterprise. Another fascinating characteristic of hospitals that generally goes unnoticed is the breadth, range, and variety of services that are delivered within the same facility. The process knowledge spectrum. The process knowledge spectrum in healthcare is unique and native to the hospitals, rendering a layer of complexity that is unmatched. Hospitals are a polyplex, hybrid, and complex. We will now try to classify into a framework the broad spectrum of process knowledge that is unique but commonplace to hospitals. And we will do this based on the modes of care. Right? So if you look at the modes of care in a hospital that drives the process knowledge spectrum, these modes of care can be classified as repetitive, or they are customized and iterative, or they can be experimental. So as an example, within the hospital, or within the same hospital, it is not uncommon to find a nurse administering a vaccine, while in a different area, a doctor is inserting a central line at the emergency room, which might take him a few minutes. And at the same time, one of his senior colleagues might be performing a complex laparoscopic or a robotic procedure that could take her up to 6 to 8 hours. I doubt if many other systems make such demands of the process knowledge spectrum as hospitals do of their caregivers. So, let's look at how decisions and tasks are impacted depending on if the modes of care are repetitive, iterative, or experimental. I'll provide you with some examples, how the nature of knowledge differs between these three modes of care, how should the care process look like for each of these three different modes of care, what should be the clinical lead focus in each of them, and finally, the lead attention. So in a repetitive situation, right, the decisions will be standard and fairly binary. An example of this would be diabetes, cardiovascular diseases, procedures like central line insertion, where the nature of care, where the nature of knowledge, is understood and predictable. And therefore, the care process follows a standardized protocol, and the clinical lead generally focuses on minimizing variation, and the lead attention is systemic. However, in an iterative situation, the decision is heuristics based, but the heuristics is validated. For example, cancer of the pancreas, where the nature of knowledge is known, but not known with the same level of predictability as it was with cardiovascular or diabetes. So there is a predictability and there's a level of uncertainty, but within a range. And therefore, even though there's a protocol, the protocol has subroutines because the clinical lead has to optimize the selection of the subroutine based on the patient and based on the disease condition. And therefore, the attention is both systemic and also patient-centric. When it comes to experimental, the heuristics are untested. For example, Alzheimer's, lupus, where the nature of knowledge is still poorly understood or still emergent. And therefore, the care process is customized and is also highly emergent. And the lead focus, the lead clinical focus, is to discover new solutions. And the focus is highly personalized, precision, and individualized. The modes of care, the design of care plans, and the focus of clinical attention, as you saw, vary widely depending on where the patient's disease condition resides within this process knowledge spectrum. This breadth of knowledge is breathtaking and is uncommon in most industries. It further highlights the complexity that is native to hospitals, and only doctors intimately understand the nuances surrounding this process knowledge spectrum. I don't think that a fancy suit in finance or an investment banker who might have a seat on the board will be able to understand the depth of such process knowledge complexity. And therefore, doctors ceding too much management space or too much leadership space to non-medical professionals under such circumstances is a monumental folly. It undermines the very foundation of effective healthcare leadership. If there was only one argument that I was asked to use to persuade doctors to participate and engage actively with and in management or leadership roles, then it would be the content of this slide. The basis for the framework was developed by Professor Richard Boehmer, and it encapsulates how current knowledge of a disease condition affects care plan, clinical focus, and diagnostic decisions. As I said earlier, and I would like to reiterate it again, I want to make a distinction between leadership and management. And I insist that doctors cannot cede leadership responsibility. Leadership, or the art of providing direction, doing the right thing. I can understand that because of practical constraints, doctors might not be able to be involved with day-to-day management, the art of doing things right. But I think distancing themselves from leadership is not wise. And then, as if all of these twists hybrid nature, polyplex, process knowledge spectrum, all of this was not enough. The hospital system is also assaulted by a mix of stakeholder groups, all jostling for space, all having divergent agendas. Given their unique roles and quirks, I refer to them as hospital avengers. Let's meet them now.